Hello everybody. Welcome to our YouTube channel number 1 Doctor. Today we have a medical discussion with one of the famous endocrine surgeon in the world. We will talk about solitary thyroid nodule. Doctor. True solitary thyroid nodules occur in 0.22-1.35% of the pediatric population and in close to 4% of the adult population. However, suspected thyroid nodules merit close attention in the pediatric population, because such nodules are much more likely to be malignant in children than they are in adults. In addition, thyroid cancer is much more aggressive in children and is associated with early metastasis to regional lymph nodes and parenchymal organs, most commonly the lungs and bones. Doctor. What are the signs and symptoms of solitary thyroid nodules?
Benign versus malignant nodules. Benign masses are usually movable, soft, and non-tender. Malignancy is associated with a hard nodule, fixation to surrounding tissue, and regional lymphadenopathy. Reported rapid growth or recurrent laryngeal nerve dysfunction found on examination may indicate malignancy and local infiltration. If medullary carcinoma is suspected in conjunction with multiple endocrine neoplasia, MEN, 2B, multiple mucosal neuromas, marfanoid body habitus, and skeletal defects may be evident. Hormonal imbalance. Although most patients are asymptomatic, some exhibit signs and symptoms of altered levels of thyroid hormone, as follows: hyperthyroidism, nervousness, heat intolerance, diarrhea, muscle weakness, and loss of weight and appetite. In rare cases, exophthalmos may be present in a person with a hyperfunctioning nodule. Hypothyroidism may result in cold intolerance, constipation, fatigue, and weight gain, which, in children, is primarily caused by the accumulation of myxomatous fluid. Nerve involvement. Signs and symptoms of local nerve involvement should trigger rapid investigation, because such involvement may be indicative of local invasiveness from malignancy. The most important of these signs are dysphagia and hoarseness.
Doctor. What about diagnosis of solitary thyroid nodule?
Laboratory studies. Thyroid function tests. An elevated thyroid stimulating hormone (TSH) level may indicate a genesis of a thyroid lobe or thyroiditis. A very low TSH level indicates an autonomous or hyperfunctioning nodule. Antithyroid antibodies, helpful in diagnosing chronic lymphocytic thyroiditis, Hashimoto thyroiditis. Complete blood count (CBC), if abscess is suspected. Calcium levels should be monitored immediately post-operatively to assess parathyroid function and the need for supplementation. Imaging studies. Ultrasonography, to determine whether the nodule is cystic, solid, or mixed. Radioiodine scintigraphy, to determine whether the nodule is cold, warm, or hot. Chest radiography, if malignancy is suspected, given the high incidence of early metastases to the lungs. Computed tomography, CT, scanning and magnetic resonance imaging, MRI, to analyze the extent of disease by scanning the neck and chest. Regarding histology, follicular adenomas present the most common histology. These tumors maintain the follicular architecture of the gland and are usually encapsulated, without evidence of infiltration. The 4 major malignancies that may be found in the thyroid gland are papillary carcinoma, follicular carcinoma, anaplastic carcinoma, and medullary thyroid cancer.
Doctor. What about pathophysiology of solitary thyroid nodule?
Although benign tumors are the most common cause of thyroid nodules in children, because of the higher rates of malignancy in this population, consider the possibility of neoplasia in the presence of a solitary thyroid nodule. Missed malignancy is tragic, but the prospect of lifetime hormone replacement therapy in the absence of pathological need is frustrating, making accurate diagnosis much more vital in the pediatric population. A palpated mass may be solid, cystic, or mixed in nature. Benign cysts can be evacuated successfully by aspiration, usually with no recurrence. The aspirated fluid is usually clear yellow or bloody, with high levels of thyroid hormones. Rarely, a parathyroid cyst is aspirated. In this case, the fluid is clear and colorless, with high levels of parathyroid hormone. A true cyst has a very low risk of malignancy. However, the presence of a cyst does not exclude neoplasia, especially if the mass is mixed. Desjardins et al. Found that 1/2 of their patients with thyroid carcinoma had a cystic component in the tumor. If a palpated mass is diagnosed as a truly solitary solid thyroid nodule, scintigraphy enables the physician to classify its activity into hot, warm, or cold. Some authorities recommend that, because definitive diagnosis can only be made with fine needle aspiration biopsy (FNAB) or excisional biopsy findings, scintigraphy findings should have a limited role in the initial diagnosis and management of thyroid nodules. However, these authors feel that radioactive iodine uptake characteristics of nodules can direct treatment and assist in estimating risk of malignancy. Hot or autonomous nodules are less common in the pediatric population, comprising 5% of all nodules. These nodules have their own regulation and may suppress the rest of the gland. This autoregulation may cause hyperthyroidism and thyrotoxicosis. Hot nodules are fairly common in adults, comprising 25% of palpable nodules, and may be associated with Graves' disease. The relative rarity in children is balanced somewhat by a higher tendency for thyrotoxicosis and malignancy. In children, speed of progression tends to be higher, with increased aggressiveness. However, gradual progression is also common. Initial symptoms may be insidious, such as mood and behavior changes, and may be overlooked. Typically, most toxic nodules should be considered for surgical excision after the preoperative administration of antithyroid medications. The risk of malignancy in hot nodules in children is estimated at 2 to 18%, compared with less than 1% in adults. Therefore, one should not ignore the possibility of neoplasia. Pay careful attention to any histologic specimens, because toxic nodules can displace papillary structures that resemble papillary cancer. Warm nodules are usually functioning at enemas. However, they may harbor malignancy or represent testing error. By definition, the nodule shows some function on scintigraphy, but the patient remains euthyroid. Controversy surrounds specific treatment recommendations. Some sources group warm nodules with hot nodules, whereas others group them with cold nodules. The risk of malignancy in this group is very low. Therefore, these nodules can generally be observed. However, if the patient has signs and symptoms suspicious for cancer, such as growth of the nodule, fixation to tissues, or lymphadenopathy, the nodule should be surgically excised. Observation of a warm nodule may be the optimal course. However, care should be taken to maintain follow-up with the patient. The solitary cold nodule is the most commonly discovered type in children, comprising 40 to 70% of all nodules. In addition, solitary cold nodules have the highest risk of malignancy, 17 to 36%. Most commonly, cold nodules are follicular adenomas or other benign processes such as chronic lymphocytic thyroiditis, Hashimoto thyroiditis, or Hürthle cell hyperplasia. They may also represent ectopic tissue or other benign process, such as benign lymphadenopathy or abscess. Definitive diagnosis can only be histologically made. Hashimoto thyroiditis may cause cold nodules. It occurs in 1% of school-aged children and may present as a nodule, have generalized swelling, or be undetectable upon clinical examination. It is generally felt to be a T-cell-mediated autoimmune disorder with histologic evidence of lymphocytic invasion of thyroid tissue, usually resulting in hypothyroidism. However, in 5 to 10% of patients, it may present initially as transient hyperthyroidism. Diagnosis is confirmed by measurement of antithyroid antibodies, including antibodies directed against thyroperoxidase, which may play a role in the development of the thyroid dysfunction.
Doctor, what about characteristics of the nodule?
The history of the mass should be reviewed carefully. Time of initial appearance, rate of growth, and any associated symptoms especially can assist the clinician in determining the malignancy potential of the mass. Rapid growth is an indicator of malignancy. Therefore, further diagnostic tests should be expediently obtained. Transient tenderness within the mass at any time may signify an inflammatory process. However, this same symptom may also be caused by tumor hemorrhage, necrosis, or cyst formation. This information can be used to assist the clinician in determining malignancy of the mass.
Doctor, what about physical examination of the solitary thyroid nodule?
In patients with a thyroid mass, careful physical examination is a key step in evaluating malignancy. Most patients are asymptomatic, but exophthalmos rarely may be present in a person with a hyperfunctioning nodule. In one study, 55% of pediatric patients with thyroid cancer had no other symptoms than a neck mass, whereas 23% had only neck and cervical masses. Therefore, the lack of symptoms should not preclude thorough evaluation. Careful examination of the neck reveals the nature, location, and tenderness of the mass, fixation of the thyroid to surrounding tissue, and the presence of other cervical masses, which can be metastases or lymphadenopathy. Benign masses are usually movable, soft, and non-tender. Malignancy is associated with a hard nodule, fixation to surrounding tissue, and regional lymphadenopathy.
What are the causes of solitary thyroid nodule?
Many risk factors are associated with the development of thyroid nodules and cancer. A family history of thyroid disease, benign or malignant, significantly increases risk. Fowler et al. Found that a family history of thyroid disease was present in 41% of their patients with thyroid nodules. 10. A family history of endocrine tumors also has been shown to increase risk, especially in persons with men. Increased risk has been found in some endemic areas, although environmental reasons have not been elucidated fully. In the pediatric population, pubertal girls are more likely to develop a thyroid nodule, although the risk of malignancy in these individuals is lower than that in boys. Thyroid disease has also been. Exposure to certain carcinogens predisposes patients to the development of thyroid disease. Previous head and neck irradiation is the most obvious and well-known risk factor. In the first half of the 20th century, head and neck irradiation was used widely for treating a number of benign conditions, including acne, tonsillar enlargement, thymic enlargement, and tinea capitis. During this period, the incidence of thyroid nodules in children and the risk of malignancy in the nodules were much higher. In the 1950s, 70% of thyroid nodules in children harbored malignancy. Fortunately, widespread misuse of irradiation has ceased, and malignancy rates have fallen.
Doctor, what about the differential diagnoses of thyroid nodules?
Agenesis of one lobe, unilateral thyroid agenesis. Anaplastic thyroid carcinoma. Asymmetric enlargement of one lobe. Chronic lymphocytic or autoimmune or Hashimoto thyroiditis. Colloid cysts. Colloid nodule and or multinodular goiter. Cystic hygroma, macrocystic lymphatic malformation. Developmental error. Follicular thyroid carcinoma. Follicular adenoma. Germ cell tumor of the neck. Hürthle cell carcinoma. Hyperplastic nodules. Pediatric lymph node disorders. Lymphadenopathy. Lymphoma. Medullary thyroid carcinoma. Neck infection and or abscess. Papillary thyroid carcinoma. Papillary adenoma. Pediatric Graves' disease. Pediatric hyperthyroidism. Pediatric multiple endocrine neoplasia. Thyroid abscess. Thyroiditis.
Doctor, What about treatment of solitary thyroid nodule?
1. Medical care. After initial diagnosis and investigation of the thyroid nodule, medical and/or surgical therapy is decided. A presumed benign nodule, especially in an adolescent, may simply be observed. Close observation and follow-up care is essential. The patient should be closely monitored for change of size and the development of symptoms. Treatment of autoimmune thyroiditis involves hormone replacement to maintain a euthyroid state. Treat infection appropriately. Abscesses should be drained and antibiotics should be administered. In patients with immunocompromise, be aware of the remote possibility of local spread to mediastinal structures. A warm nodule without physical signs of malignancy is usually benign and may be observed with close follow-up for growth or change in the nodule. A hot toxic nodule may require medical therapy before surgical removal to allow for operative stability. The patient should receive suppressive doses of antithyroid medications. Once physiologic stability is obtained, the surgeon can proceed with removal of the gland or lobe. In the past, preoperative thyroid suppression was used to exclude benign disease. This no longer is recommended for several reasons. For example, the incidence of cancer in childhood thyroid nodules is high, and well-differentiated cancers may respond, delaying definitive diagnosis and treatment. Routine preoperative and post-operative care includes the maintenance of nutrition and hydration as well as the observation for signs of complications. The pediatrician or other primary care provider should closely cooperate with the surgeon to monitor for nerve injury or hypocalcemia. Calcium supplementation may be necessary in the individual with parathyroid compromise, whether temporarily or permanently. Closely monitor laboratory findings to determine the initial and ongoing requirements. Recurrent laryngeal nerve injuries may cause dysphagia, which can endanger nutrition. In such an individual, involve speech pathology early to optimize recovery. After thyroidectomy, thyroid hormone replacement is necessary. This therapy is continued for the child's lifetime. Thyroid hormone levels should be monitored periodically so that adequate therapy is maintained during growth and changing needs. If malignancy is diagnosed, radioablation therapy may be used for any residual disease. Long-term follow-up care remains vital in such individuals to screen for disease progression or late recurrence. 2. Surgical care. The presence of a thyroid nodule in children presents somewhat of a dilemma, given the less than ideal reliability of diagnostic tests. However, the increased incidence of malignancy in pediatric nodules has led to a somewhat more aggressive approach than that used in adults. Indications for surgical excision include physical examination findings consistent with malignancy, persistence of a nodule, progressive increase in size, or the presence of significant risk factors, including family history or history of irradiation exposure. All toxic nodules in children should be removed. If the presence of malignancy is still in question after diagnostic tests and procedures have been completed, perform surgical excision. Some authorities recommend the removal of all non-suppressible thyroid nodules found in children younger than 13 years. In the presence of a small asymptomatic nodule, the surgeon may elect to perform a simple lobectomy with close follow-up observation. Complications with this surgery are generally low. In such an individual, full thyroid suppression also is recommended as lifetime post-operative therapy. Many adenomas contain mutations, causing them to be hyperresponsive to thyroid-stimulating hormone. The presence of such an adenoma may signify the presence of other cells bearing the same mutations.
Doctor, what about total thyroidectomy as a treatment of thyroid nodules?
Total thyroidectomy. With the presence of any metastases on diagnosis, including lymph node involvement, total thyroidectomy is the recommended treatment. This procedure has decreased the rates of local and metastatic recurrence. Post-operative radioablation is also more effective in this case because tissue to absorb the radioiodine is reduced. Because the rate of pulmonary metastasis is high, Post-operative radioiodine scintigraphy is performed 6 weeks after surgery to exclude the presence of pulmonary tumors. Scintigraphy is only reliable after total or subtotal thyroidectomy, because any remaining tissue may hide the presence of metastases. Total thyroidectomy should be performed in individuals with medullary thyroid cancer, preferably before evidence of disease is obvious. This malignancy is aggressive and metastasizes early. Prophylactic therapy, with removal of the gland in children with a family history and genetic markers, provides the best outcomes with this malignancy. If Graves' disease is diagnosed, thyroidectomy near total to total may be performed. Thyroid hormone replacement therapy may not be needed in this case if some tissue remains.
Doctor, what are the guidelines?
The American Thyroid Association issued management guidelines for children with thyroid nodules and differentiated thyroid cancer. The guidelines included some of the following recommendations: for children at high risk for thyroid neoplasia, an annual physical examination is recommended, and if the examination finds palpable nodules, thyroid asymmetry, and/or abnormal cervical lymphadenopathy, additional imaging is warranted. Instead of size alone, ultrasound characteristics and clinical context should be used to identify nodules that merit fine needle aspiration, which should be implemented using ultrasound guidance. Lobectomy may be done in patients with compressive symptoms and cosmetic concerns, or if the patient or parent prefers. Consider lobectomy in all benign appearing solid thyroid nodules greater than 4 cm, the lesions that have grown significantly, or if malignancy is a concern.
Thanks, doctor, for this excellent discussion. Hope to see you again in more medical discussions. With my best wishes. Dr. 8 Famad.